Okay, today we are going to learn about the basics in the implant also. Okay. We will the classification of the implants, the parts of the implants, the basic concept of osseointegration, and like that. Okay. So usually questions comes like concept of osseointegration, history of implants, surface characteristics, this knowledge of various types of implants. This is a syllabus. Okay, usually comes like this. And the bone biology, the morphology, classification of bone, and its relevance to implant placement, bone augmentation, like graft materials, everything comes under this implant. This is in the syllabus. Okay, and usually I've seen some simple questions like in the like short notes, like types of implants, osseointegration, zygomatic implants, which asked last time, complications and sinus lift. Okay. So we can start with the basic definition. Okay. So an dental implant is a biologic or alloplastic biomaterial which is surgically inserted into the soft and hard tissues of the mouth for functional or cosmetic purposes. This was defined by Carl E. Mesh in 1980. Okay. Then, according to the Glossary of Periodontal Terms 2001, that is, the American Academy of Periodontology has described the dental implants as a dental implant is an alloplastic material or device that is surgically placed into oral tissue beneath the mucosal or periosteal layer or within the bone for function, therapeutic, or aesthetic purposes. Okay. The history of the implant starts with the 500 BC, it's a long term back, where the Egyptians were using the gold wire ligatures for as a cause for stabilization of the tooth. Okay, it started with 2500 BC. Then in 500 BC, the animal bones were implanted in, like for replacing the natural teeth. Then after 500 BC, it took another lot of years to find out what's the basics or the basis of the why the implant is also integrated or it is bonded in the bone. So in 1952, the concept of osseointegration was described by Per Ingvar Brennemer, who is known as the father of the implant of us. Okay. Then again, it took into the 1990s to discover the titanium implants. Okay, it was again 90s. During the 1990s, titanium was in the titanium implants were used. Then the all-on-4 concept, another breakthrough, was found in 1998. So the history of implant has got a large use of history. Okay. Then the concept of osseointegration, as I told, it was discovered by or described by Per Ingvar Brennemer. So he described and defined it as direct structural and functional connection between ordered living bone and the surface of the load carrying implant. That is, there is a connection which is structural as well as functional found between the implant and the bone surface. Okay. The same definition that is Per Ingvar Brennemer was given to osseointegration. Okay, so if we check into details, we can find that the surface of the titanium implant has its oxide, that is titanium dioxide, the titanium peroxide compound that forms on the layer of the implant can deactivate the inflammatory cells, thus reduces the foreign body reaction. If anything, any metal that is which is not inert can cause foreign body reaction in our body when it is placed into the bone. But the titanium has got a peroxide compounds which can help to reduce the inflammatory reaction. That's why this occurs. Again, it's got a reaction with titanium dioxide, which also protects against the corrosion. Okay, and the calcium and peroxide ions can improve the bone to implant contact. Also, we will treat the surface of the implant with some chemicals or thermal methods or machine, which can be helped to improve the bone to implant contact by making micropores. Okay, so it can improve the physical or chemical anchor system, which augments the load bearing capacity, increases the tensile strength, also increases the healing rate. Okay, that is surface treatment can increase the stability or longevity of the implants. Okay, these are other definitions of the osseointegration. Okay, then we can move on to the parts of our implant. Okay, so what you can see here as this one, a cylinder-like thing. You can see the five one is the last one. Okay, here you can see the abutment. That is the fixture, not the abutment. It's the fixture. That's the implant fixture, which is the main part of an implant system. Okay, which has got many design. You can see the spiral design, you can see the flat or design, you can see the threaded like something. The design can be varied based on the type of the implant which we are using. Okay, then we have got the abutment, which is you can see just above this above the fixture. Then you can see the cover screw. The cover screw is a screw like thing. You can see here. This is a cover screw. Then we have got the healing abutments, the plastic healing cap, everything. So the main part of the fixture abutment, the cover screw. Okay. Then the if for taking the impressions, we have got the impression copies, etc. Okay. Then for making the so for making the process, we have to keep an analog for the laboratory. So we have got a lab analog also. Okay. For dental implants can be placed where we have got good oral hygiene, good periodontal height, low disease activity, adequate bone quantity and quality, well motivated patients with space maintenance and orthodontic anchorage also. Okay, there are some contraindications. The uncontrolled systemic condition, especially diabetes mellitus, so we have to check whether the patient is is diabetic for past few years, so that you have to check the glycosylated hemoglobin value before you are planning for an implant placement. Then uncontrolled hypertension, like any surgeries, we have to control it. The steroid therapy, which can reduce the immunity. The patient having poor oral hygiene and the smoker and has got high dose irradiation after any diseases and occlusal trauma also. Okay. Then the classification of implants. The classification starts with based on the implant design. We can classify it into endosseous implants, which is placed inside the bone. That is only passes through one cortex. See, that is placed inside the jawbone, but it pierces through only one cortex. The lower border is not pierced. Okay. If you passes through the lower cortex also, then it becomes a transosteal implants. Then if it is placed beyond the periosteum, there is known as a subperiosteum, which we are not using much. Okay, then there are some intramucosal implants also. There is, it is placed into the mucosa. Okay. Then based on the surface of implant, it can be smooth surface where no chemicals or no machines are used to improve its surface qualities or properties. Okay. Then we have got machined surface. Then we have got textured surface and coated surface. Okay, that is physically or chemically coated. Okay. Then classification of dental implants based on the implant body design. There is a tapered one, solid one, threaded, cylindrical, hollow, or disc-like. Okay. Then the types of implant based on whether it is using as a single piece or dual piece implants. Which is in the single piece, there is a compression screw design, cortical screw design, basal osseointegration or transosseous implants. Then we have got a two-piece system There it is the abutment is a separate one. Okay, so it is straight or angulated, short or wide implants. Okay. Then based on the timing of implant placement, there is an immediate, early or delayed. Immediate is immediately placed after extraction. Then early means 4 to 6 weeks after extraction, and delayed means 6 months after extraction. That is proper bone formation after extraction. Okay. Then this is a protocol for placing. This is a Hammerley's classification. That is type 1, where the implant placement is immediately following the tooth extraction as a part of some same surgical procedure. Okay. So in this we can reduce the amount of surgical procedures and reduce the overall treatment time, everything. Then the major disadvantage is the site morphology can complicate optimal placement and anchorage. We cannot plan for any optimal placement or the angulation or the depth, which is difficult for us to plan. Okay. Then there is a lack of keratinized tissue that can compromise optimal outcome of this procedure. Okay. Then for type 2, there is a which is early placement, that is 4 to 8 weeks after extraction. Okay, it increases soft tissue area and volume, because after 4 to 6 there will be some amount of resorption, and the area will be much more easier for us to place the implant. But again, the site morphology can be somewhat complicated. Okay, treatment time is also increased. We have to past 4 to 8 weeks. Okay, then the type that is substantial clinical and radiographic bone filling, that after placing after 12 to 16 weeks. We have to check for the radiographs, and if the bone is formed, we can place it. Okay. Type of healed site, that is completely healed and completely bone formed after placing after bone formation, that is after 16 weeks. Okay. Then we have got the loading protocols, that is immediate loading. Where if the primary stability is achieved, we can place it. That is, if we place the implant at 35 Newton meters of torque, we can immediately load. Loading means every time we are placing the crown and it is in function. Okay. Then early loading is there. Conventional loading is there. Then there is delayed loading. Okay. Then this is a last part of the interaction, that is the comparison of the implant with the root. Okay, we can see the peri-implant connective tissue is completely lacked in case of the implant. That is, we don't have any periodontal ligaments. Okay, the biological width of 3 to 4 millimeters is there with the periodontal ligaments. Okay, the natural tooth. Okay, there is 2 to 3 mm of epithelial attachment, or 2 mm subcostal connective tissues. Okay, due to lack of pedial ligaments, no resilient connection is between implant and the surrounding bone. Then the proprioception is lost because there is no fibers. Okay, peri-implant connective tissue runs. There is a connective tissue attachment, but it runs more or less parallel to the implant, but the pedial ligaments can run perpendicular to it. Okay, so this is a basics in implantology. Next class we can tell more about the concept of osseointegration.